Chapter 40, Inflammatory and Structural Heart Disorders. It could be classified many different ways. By cause, with IV drug use being very common, and also fungal infections. It could also be that by the site of involvement, including a prosthetic valve endocarditis, where the prosthetic valve itself begins to grow a pathogen. In the subacute form that affects those with pre-existing valve disease, and the acute form that affects those with healthy valves. It could also be classified by the causative organism, with bacterial being the most common, staph and strep especially. It could also be due to viruses and fungi. In our case study, EF is a 72-year-old man who's come to the clinic with flu-like symptoms. He has a history of hypertension, past MRSA infection, and a recently implanted pacemaker. Risk factors would include categories of high, moderate, and low risk for developing infective endocarditis. The principal risk factors are prosthetic valves, hemodialysis, and IV drug use. What risk factors for infective endocarditis does our patient have? That MRSA especially, along with a pacemaker, both of which could introduce those pathogens to his heart valves. The etiology and pathophysiology, it occurs in three stages: bacteremia, adhesion, and vegetation. During vegetation, fibrin, leukocytes, platelets, and microbes all play a role in sticking to the valve or the endocardium within the heart. As parts break off, they begin to enter the circulation, embolization. In the case of left-sided vegetation, this can move to the brain, kidneys, and spleen, while in right-sided vegetation, it will move to the lungs. Here in figure 36-3, we have the pathogenesis of infective endocarditis. It begins with that damage to the endothelium surface from anatomic or traumatic changes, and from there that allows an opportunistic pathogen to take hold and grow. What clinical manifestations of infective endocarditis does EF present with? And what other manifestations of infective endocarditis would you assess him for? Again, that flu-like symptoms is going to be a major key. These manifestations can take a lot of different forms: nonspecific, fever, chills, weakness, malaise, fatigue, or anorexia. In the subacute form, it could manifest as arthralgias, myalgias, back pain, abdominal discomfort, weight loss, headache, or clubbing of the fingers. In vascular manifestations, it could be a splinter hemorrhage within the nail beds, petechiae, Osler nodes on fingertips or toes, Janeway's lesions on the pads of the fingers and toes, or Roth spots. Other clinical manifestations could include new or worsening systolic murmur that occurs in most patients, heart failure, or manifestations secondary to septic embolism like central nervous system issues, extremities, spleen, or kidneys. EF has petechiae in the conjunctiva and splinter hemorrhages within his nail beds. His blood pressure is 138/64, a heart rate of 80, respiratory rate of 18, and a temperature of 99.5. A heart murmur is also noted. The healthcare provider suspects infective endocarditis. EF is sent to the hospital for further workup and treatment. What diagnostic studies would you expect the admitting healthcare provider to order for EF? Diagnostic studies would include a thorough history, along with laboratory tests like blood cultures, CBCs, and an echocardiogram. Also, chest x-rays may also be considered. Prophylactic antibiotic treatment for select patients having certain dental procedures, respiratory tract incisions, tonsillectomy and adenoidectomies, surgical procedures involving infected skin structures, or musculoskeletal tissue. And all of these can provide an opening for an opportunistic pathogen to take hold. EF's blood culture results are positive for Staphylococcus aureus. An echocardiogram demonstrates vegetation on his mitral valve. What treatment would you expect the healthcare provider to order for EF? Step 1 would be an accurate identification of the organism, with IV antibiotics long-term, repeat blood cultures, valve replacement if needed, antipyretics, fluids, and rest. For our subjective data, it's going to include a health history, including valvular, congenital, or syphilitic heart disease, previous endocarditis, or staph or strep infection. We'll also look into drugs that may also be acting as immunosuppressants. Other subjective data would include a history of IV drug use, alcohol abuse, weight changes, chills, hematuria, exercise intolerance, weakness, fatigue, cough, orthopnea, night sweats, pain, headache, joint, or muscle tenderness. Other objective data would include arthralgia and myalgias, petechiae, purpura, Osler's nodes, splinter hemorrhages, or Janeway's lesions. EF is started on IV antibiotics and seems to be resting comfortably. He occasionally requests pain medication for achiness and continues to have a low-grade fever. He is not showing any symptoms of heart failure at this time. Identify any appropriate nursing diagnoses or goals for EF. Our overall goals should include normal or baseline function, an ability to perform ADLs without fatigue, and an understanding of the treatment plan to prevent recurrence. For health promotion, we want to identify those at risk, assess the history and their understanding of the disease process, and teach the importance of adherence to the treatment regimen. Other patient teaching would include stressing the need to avoid infectious people, of the avoidance of stress and fatigue, planning rest periods, good oral hygiene, prophylactic antibiotics, and drug rehabilitation. Ambulatory care would include antibiotic therapy for 4 to 6 weeks, assessing the home setting, monitoring laboratory data, including blood cultures, assessing IV lines, and coping strategies. For ambulatory care would include adequate rest, moderating activity, compression stockings, range of motion exercises, and deep breath and cough every 2 hours. EF has completed a week of IV antibiotic therapy in the hospital setting. He is afebrile and feeling better. Social service has arranged for home IV antibiotic therapy in anticipation of a discharge to home. What important patient and caregiver teaching should you provide EF and his family? Things like a normal and baseline cardiac function, the performance of activities of daily living without fatigue, and the knowledge of the therapeutic regimen to prevent recurrence of endocarditis. You also want to teach him what the treatment will involve and what he will need to do after treatment to prevent recurrence, such as prophylactic antibiotics and the need to avoid infectious people, the avoidance of stress and fatigue, and including adequate rest and hygiene. For patient teaching, we should monitor the patient's body temperature closely, along with any signs and symptoms of complications. Understand the nature of the disease and how to reduce the risk of reinfection. Stress the follow-up care, good nutrition, prompt treatment of common infections, as well as the signs and symptoms of infection to be on the lookout for. Expected outcomes are that the patient will maintain adequate tissue and organ perfusion, maintain normal body temperature, and report an increase in physical or emotional comfort. Valvular heart disease. In the case of valvular heart disease, the heart has 2 arterioventricular valves, the mitral and the tricuspid. It also has 2 semilunar valves, the aortic and pulmonic. Types of valvular heart disease is defined according to the valves affected, as well as the type of dysfunction such as stenosis or regurgitation. Stenosis is a constricting or narrowing, and in this case the valve opening is smaller, and this is causing an impediment forward of the blood flow. The pressure differences on the 2 sides of the valve reflect the degree of stenosis. Regurgitation, on the other hand, is the incompetence or insufficiency, and it's the incomplete closure of the valve leaflets, and this results in a backwards flow of blood with the contraction. In the case of valvular stenosis and regurgitation, on the left here we have a normal valve with a cusp and a normal valve closed, while on the right-hand side we have a stenosed valve, both open and closed. In the case of mitral valve stenosis, this is most commonly caused by rheumatic heart disease, and in this case, scarring of the valve leaflets and the cordon tendineae, as the contractures develop with adhesions between the commissures of the leaflets, causing the valve to close incompletely. Mitral valve stenosis results in decreased blood flow from the left atrium to the left ventricle. It also causes increased left arterial pressure and volume. This results in increased pulmonary vasculature pressure and a risk for AFib. Here in figure 36-7C and D, we have a stenosed mitral valve on the left and a regurgitant mitral valve on the right. Clinical manifestations include exertional dyspnea, a loud S1, a diastolic murmur, fatigue, palpitations, hoarseness, hemoptysis, and atrial fibrillation with risk for stroke. Normal valve function depends on the intact mitral leaflets, mitral annulus, the cord and tendineae, and papillary muscles. It can resolve when damage is caused by things like an MI, chronic rheumatic heart disease, mitral valve prolapse, or ischemic papillary muscle dysfunction. Mitral valve regurgitation is an incomplete valve closure that results in backward flow of blood. In the case of an acute mitral valve regurgitation, you're going to start seeing pulmonary edema, while chronic mitral valve regurgitation is going to result in left atrial enlargement, ventricular dilation, eventual ventricular hypertrophy, and eventually heart failure. Acute clinical manifestations include thready peripheral pulses and cool, clammy extremities. Chronic clinical manifestations include asymptomatic for years, along with weakness, fatigue, palpitations, dyspnea, that eventually progresses to orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, and an audible S3 murmur. Mitral valve prolapse is the abnormality of the mitral valve leaflets and the papillary muscle or chordae. The leaflets prolapse backwards into the left atrium during systole. This is usually benign with the valve closing effectively. It results in potential complications. While its cause is unknown, there is a genetic link. Here in this figure 36-8, we have a cross-section of the heart with a mitral valve prolapse there identified with the arrow. A mitral valve prolapse is confirmed with an echocardiogram, along with clinical manifestations, such as things like most patients are asymptomatic for life, only 10% with symptoms. The murmur is due to regurgitation, and severe mitral valve regurgitation is uncommon. Clinical manifestations could also include dysrhythmias that can cause palpitations, lightheadedness, and syncope, infective endocarditis, and chest pain that's unresponsive to nitrates. It can also be treated with beta blockers or valve surgeries. Mitral valve prolapses, patient teaching is important, including antibiotic prophylaxis if the mitral valve regurgitation is present, taking drugs as prescribed, a healthy diet that includes avoiding caffeine, avoiding over-the-counter stimulants, exercise, and teaching on when to call the healthcare provider and EMS. Aortic valve stenosis is a congenital aortic stenosis usually found in childhood, adolescence, or young adulthood. In adults, it can be degenerative or caused by rheumatic fever. In the case of aortic valve stenosis, this is an obstruction of blood flow from the left ventricle to the aorta. Left ventricular hypertrophy and increased myocardial oxygen consumption, and decreased cardiac output that leads to decreased tissue perfusion, pulmonary hypertension, and heart failure. It also has a poor prognosis if left untreated. Clinical manifestations include angina, syncope, and exertional dyspnea. Osculatory findings include a normal to soft S1, decreased or absent S2, systolic murmur with radiation to the carotids, and a prominent S4. Unfortunately, aortic valve stenosis has a poor prognosis if symptomatic and not corrected. Use nitroglycerin cautiously, as it reduces the preload and blood pressure and can actually worsen chest pain. In the case of aortic valve regurgitation, acute aortic regurgitation is due to things like infective endocarditis, trauma, or aortic dissection, and should be considered a life-threatening emergency. Chronic aortic regurgitation, on the other hand, is due to things like rheumatic heart disease, congenital bicuspid aortic valves, syphilis, connective tissue problems, or even have post-surgical causes. Aortic valve regurgitation is the backward blood flow from the ascending aorta into the left ventricle. With chronic aortic regurgitation, the left ventricular dilation and hypertrophy result. This leads to decrease in the myocardial contractility and the pulmonary hypertension and right ventricular failure. Clinical manifestations of acute aortic regurgitation include severe dyspnea, chest pain, hypotension, cardiogenic shock, and again, this is a life-threatening emergency. Clinical manifestations of chronic aortic regurgitation, the patient may be asymptomatic for years, and have exertional dyspnea, orthopnea, or paroxysmal dyspnea. They could also have angina or a water hammer pulse if it's severe. Soft or absent S1 sound would be common, along with an S3 or S4 sound, even a murmur. In the case of tricuspid valve stenosis, it is almost always caused by rheumatic fever, with clinical manifestations including a fluttering discomfort in the neck, fatigue, and right upper quadrant pain. On the other hand, pulmonic valve stenosis is almost always congenital and causes right ventricular hypertension and hypertrophy, with clinical manifestations such as syncope, dyspnea, and angina. When dealing with valvular heart disease, there's going to be many different studies we'd use, beginning with a patient's history and physical exam. We'd then consider things like an echocardiogram or a T procedure, standing for a transesophageal echocardiogram. They may also use things like a chest x-ray, ECG, or heart catheterization. Conservative therapy would be dependent on the valve involved and the disease's severity. We also want to work to prevent exacerbations, such as things like heart failure, pulmonary edema, or thromboembolism. We're also going to be considering prophylactic antibiotic therapy to prevent any recurrent infections. Some drugs to consider would be vasodilators, positive inotropes like digoxin, diuretics, and beta blockers. This may be also combined with sodium restriction, anticoagulants, and other antidysrhythmics. In the case of a percutaneous transluminal balloon valvuloplasty, a slit open is fused commissures, meaning they actually go down with a catheter and try to force that valve back open and into place with a balloon. It treats mitral, tricuspid, pulmonic, and is that balloon-tipped catheter is inserted via the femoral artery, much like they would get for another cardiac catheterization to have a stent placed. But in this case, they're actually going to get it to the right place, blow up that balloon, and try to force it back into shape. For surgical therapy, valve repair would be the preferred surgical procedure because it has a lower operative mortality rate. Unfortunately, it may not be as effective at restoring the valve's total function, however. Other procedures to repair closed or open valves would be things like a commissurotomy or a valvulotomy. Types of valves that may be considered would be a mechanical valve because it's more durable and lasts longer. Unfortunately, it also comes with a risk of thromboembolism and they require the patient to be placed on long-term anticoagulants. On the other hand, biologic valves are another option, coming from sources such as bovine, porcine, or human. They do not require anticoagulation therapy, though are less durable. Here in figure 36-11, we just have various types of prosthetic valves. In the case of a transcatheter aortic valve replacement, this is for severe cases. It comes through the transformal approach with two types, the Edwards Sapien 3 valve or the core valve transcatheter aortic valve. Our subjective data will include a past medical history, IV drug use, fatigue, any reports of palpitations, weakness, activity intolerance, dizziness, or fainting. Also things like cough, hematitis, orthopnea, or even angina or atypical chest pain. Other objective data would be fever, diaphoresis, flushing, cyanosis, clubbing, peripheral edema, or respiratory manifestations such as crackles, wheezes, or hoarseness. Our objective data would be those adventitious heart sounds such as an S3 or an S4. Also things like dysrhythmias, an increase or decrease in pulse pressure, hypotension, a water hammer or thready peripheral pulses, hepatomegaly, ascites, or weight gain. When planning our patient goals, they would be things like the return of normal heart function, improved activity tolerance, and an understanding of the disease process, along with the health maintenance requirements. For health promotion would include early treatment of streptococcal infections, prophylactic antibiotics for patients with history, and teaching the patients what symptoms to report. We want to individualize rest and exercise and avoid strenuous activity. We also want to make sure we're discouraging tobacco use, providing an ongoing cardiac assessments to monitor drug effectiveness, and carefully monitoring the patient's INR when placed on anticoagulants. Our patient teaching would include drug actions and side effects, the importance of prophylactic antibiotic therapy, information related to anticoagulation therapy, and when to seek medical care. Follow-up care would be to notify the provider for signs of infection, heart failure, or bleeding, as well as planned invasive or dental work. They will be placed prophylactically on antibiotics. And they're also going to be taught to wear a medical alert bracelet as well. And finally, for evaluation, our expected outcomes will be to maintain adequate tissue and organ perfusion, achieve fluid and electrolyte balance, achieve the optimum level of activity, and describe the disease process and measures to prevent complications. But anyway, that's all I got for this chapter. I'll see you in the next slides.